Good evening to everyone. Thanks to Nai for inviting me for this lecture program. Okay. So today I'll be covering regarding diabetic foot ulcer treatment. Okay. So we start off with the basics of any sort of treatment for diabetic foot ulcer, where you start off with the stages of wound healing. You have to understand the physiology involved in order to treat a patient. So usually the 4 stages are, as you see, hemostasis, inflammation, proliferative, and remodeling. So all these 4 stages, right, it can occur consecutively together, meaning during hemostasis, there may be inflammation. With inflammation, they may be still having proliferation. So these stages can actually occur together. So it's important for all the stages to occur within its time limit, with optimally, and also within the given time frame. If any of this is prolonged, or there is a prolonged example of a prolonged inflammation, this will lead into a chronic wound or non-healing wound, or will temper with its healing. Okay, so this is what usually occurs in the 4 stages of the wound healing. During hemostasis, you have your vascular constriction, your platelet aggregation as your inflammation period, your proliferation, and remodeling. Okay. So during all these 4 stages, as you can see, each has its own role in wound healing. So the hemostasis will prevent patient from bleeding out. The inflammation period will help to control the bacterial load. The proliferation part will help in your reapplication, your angiogenesis, meaning you'll help to reproduce your tissue, your blood cells, your nerves. And also the last one, remodeling, will have your highest uptake of collagen, where it helps to finally close up the wound. So there's 2 types of management. One is surgical and also systemic management in treating diabetic foot ulcers. So first, let's go to the metabolic control. Okay. So usually what we say metabolic syndrome is a cluster of risk factors where you have prolonged hypertension, hyperglycemic, and also your high cholesterol levels. All this together is known as metabolic syndrome, which it's a precursor to developing your diabetes, your heart disease, and also stroke. So hyperglycemic, as explained earlier, it causes a risk of microvascular and macrovascular complication, which eventually leads to your peripheral neuropathy and also your peripheral vascular disease. So the first step would always to be educating the patient on a proper diet and lifestyle change, where you have supplements of micronutrients, regular exercise, and also optimal diabetic blood pressure, LDL cholesterol. So when it comes to micronutrients, the most common ones which is recommended to patients is vitamin C, zinc, copper, and also in certain doctors prefer to give vitamin A and also vitamin D. So all this has limited research when it comes to micronutrients, but it's always important to keep ourselves to optimize our daily nutrition intake so that our wound will be healing much faster. So when it comes to your parameters of glucose control, so your glucose, your lipids, and blood pressure should be within this given range. So if any of this is uncontrolled, you will eventually lead to your metabolic syndrome, where you start to develop diabetes, hypertension, diabetes, your heart disease, and also stroke. So this is an individual HbA1c, which you are supposed to control given a patient's profile. So usually you can take HbA1c as standard to treat your patients to see how good is their control. So as you can see, we want to keep the newly and recently diagnosed younger age patients who are at low risk below 6.5. The rest you will want to keep it at 6.6 to 7. And also in elderly patients with multiple comorbids, you wouldn't want them to be too tight, because they are quite prone to hypoglycemia, and also they have multiple other diseases which will cause prolonged wound healing. So 7.1 to 8% it's an acceptable level when you're treating an elderly patient with multiple comorbids. So this is a study showing that how good HbA1c control contributes to healing rates. As you can see, patient with about 5.48% HbA1c has a healing rate of 0.695 compared to a poorly controlled, which is at 8.82, having only a 0.04 centimeter square per day of healing. So this, it's a strong indication that diabetic sugar control is very important when it comes to healing. So you can be doing all the best dressings in the world, but as long as patient's sugar is not controlled, you will realize that you're having difficulties in healing the wound. So you can always use HbA1c as a standard. So we recommend it maybe 2 weekly or monthly check on your HbA1c to look at how good is the patient's control, and you can optimize his medications as needed. Next comes to the most important part, the vascular insufficiency, which is seen in almost all the patients. Most patients, about 80% of patients, have some sort of vascular insufficiency. So the main contribution, underlying cause will be peripheral neuropathy and ischemia from your peripheral arterial disease. So even in this presence of these factors, even moderate ischemia causes ulcers and impairs healing. Okay? So research shows that vascular compromise occurs in almost all cases, therefore becoming the most common etiology. Okay, so how does your diabetes affect? Will be, again, it contributes to your microvascular and microvascular injury by your oxygen-free radicals, your endothelial injuries. All this eventually contribute to your reduced sensation and also your atherosclerosis of your blood vessels. So tests you include digital subtraction angiography, CTA, and non-invasive oxygen measurements. The most commonly and easiest one available is always your ABSI, or your absolute total systolic index. It's not too accurate, but in a small center or where there's when you have a busy center, it gives you an idea of how good the patient's circulation is. So treatment for vascular insufficiency can consist of non-surgical and surgical management. So this is the normal abnormal values seen when you are using these particular tools to check on the vascular status. So as you can see, the transcutaneous oxygen management measurement usually is less than 40. Your ABSI is usually less than 0.8. And in case of less than 0.45, it's already severe. And when the value is more than 1.2, it's an indication of atherosclerosis. And your absolute total systolic index is usually less than 45 milligrams of mercury. So the non-surgical management of vascular insufficiency is one of it is oxygen therapy. So what oxygen therapy does, there's three modalities of oxygen therapy usually seen. Okay, first one is your hyperbaric oxygen therapy, your topical oxygen therapy, and also your continuous diffusion of oxygen therapy. So all these three has its own pros and cons. So usually the highest rate of oxygen given will be your hyperbaric oxygen therapy. However, it's usually done in a center, and also patient can only go through about 60 to 90 minutes of the therapy per day. Your topical oxygen therapy is also similar, but usually uses a single limb chamber, meaning if you have a diabetic foot ulcer, you just need to put your foot inside. And also your continuous diffusion of oxygen is where you use a particular machine and you attach it to your wound, and there's continuous diffusion of oxygen throughout the day. And it's easier because patient can bring it home. It's more feasible for the patient. But when it comes to CDO, it's just that the level of oxygen delivered is lower but constant. So it's when coming to choose patients for oxygen therapy, is usually depending on patients' comfortableness and are they available to be coming to the hospital, or they prefer to be done at home. So how it works is improves tissue hypoxia, reduces edema, enhances perfusion, reduces all your inflammatory cytokines, promotes fibroblast formation, collagen synthesis, angiogenesis, and antimicrobial effect. Because oxygen, basically, it's in every pathway of healing. So therefore, it helps in almost every aspect of wound healing. For usually, it's the common thing treatment is we are giving 100% oxygen at a level higher than the atmospheric value. So I've seen some of them actually have been using face masks and nasal prongs to put it on the wound, hoping that it gives some sort of oxygen to the wound. But the thing is, it's not the pressure is not good enough actually for your skin to absorb the given oxygen. So it's more of a waste on doing all that. So if it comes to your criteria of selecting a patient for oxygen therapies, so usually patients which have recently done any ear surgeries, any ear imbalance issues, or they have any lung specific lung issues, they are contraindicated for oxygen therapy. The side effects that I have personally seen in certain of my patients, which is very less, almost about 1% of the patients I've seen, is usually a feeling of lightheadedness, which usually resolves in an hour or two. Another therapy which is quite painless as like hyperbaric oxygen therapy. So usually both of these are quite popular because it doesn't it's not painful. It doesn't involve changing any dressings. So it usually is more comfortable for the patient. So in microcurrent therapy, it gives a certain amount of microcurrent stimulation, which increases blood flow, tissue oxygenation, and stimulates microblasts while also reducing edema. So it increases your membrane transport, your collagen matrix organization, your wound protection, and stimulation of DNA and protein synthesis, which leads to angiogenesis. So most of all this system work almost the same way. It just depends on what the patient needs and how fast is the healing. So certain patients might benefit more from microcurrent therapy. Certain patients will get more benefit from hyperbaric oxygen therapy. So also the bonus point of microcurrent therapy, it's patients usually complain of less pain. And another important is your systemic infections. So there are many antibiotics in the market. They have also a chart where they use for your mild, moderate, severe infections. But when it comes to treating a patient, it's always best to start antibiotics based on the culture. It's always good to start empirically when patients admit to our centers, but the most specific way of treating them is always will be based on culture and sensitivity. So most of the time you will not go wrong when you have a culture and sensitivity, but it's also important to treat them empirically while waiting for the results of the culture. Offloading. So offloading is defined as any measure to eliminate abnormal pressure to promote healing or prevent recurrence of diabetic foot ulcers. So there are many types of offloading: bed rest, crutch walker, total contact cast, modified footwear, rocker outsole wedge flare, insole stress relief, and metatarsal bars. So all this comes back to the physiology of the diabetic foot ulcer. So usually due to the peripheral neuropathy, in an easy term is our leg will start to, due to the autonomic defects, it doesn't sweat as it used to. So when it doesn't sweat as we walk with our abnormal gait, it usually starts to have a thick callus formation. Thick callus formation, and with your neuropathy, it starts affecting the muscles over the ankle. So your mode of walking changes. Therefore, there will be something where I think well known will be your Charcot arthropathy. So when it comes to things like Charcot arthropathy, there'll be a specific pressure over the sole. Usually, we are made to, when we are walking, our foot has an equal dispersion of pressure. However, due to all these neuropathic effects, we start to have a difficulty in movement, our gait, and also our ankle movements. Therefore, certain areas in our plantar aspect will start having excessive pressure, leading to callus and persistent abrasion over the area will start to cause a wound. Therefore, offloading is a way to decrease the pressure over the particular wound site. Usually, the area where the wound starts is always the area where it has most pressure. as the skin surrounding the wound will also have a thick callus. So this offloading system works by reducing the pressure of the wound to help heal the wound. So the gold standard is total contact cast. It's a well-molded, minimally padded cast that maintains contact with the entire plantar aspect of the foot and lower leg while also providing protection to the wound from further injury. It's usually used, plaster of Paris is used, or fiberglass, which is lighter. So it reduces the plantar pressure by increasing the weight-bearing surface area. So the indication is non-infected neuropathic foot ulcers, post-operative care, your Charcot neuroarthropathy, pre-ulcerative conditions, adequate blood supply to heal. Your contraindication if there's any signs of infection, inadequate vascular status, deep ulcers, non-compliance to patient for visits, allergy to casting material, excessive leg or foot swelling. So usually when we put patients on a total contact cast, it's more of an expertise where usually recommended would be a podiatrist to apply the total contact cast. So in case, usually what we do is we change it every 2 weekly. And during the 2 weeks, the cast is not changed. So therefore, the wound has to be clean so that it actually can withstand the time. Because if the patient has any infections or any inadequate vascular status, once when we remove the cast in 2 weeks or 3 weeks or a week, the ulcer may worsen. So this is usually the chart we use for offloading, where you can see you need a debridement, adequate vascular supply, and infection control in order to start off on your cast. So the cast should be taken care well by the patient, should not be rubbing against the skin or causing pain, and also to be getting wet. And we also should explain to the patient that in case there's any fever, chill, nausea, vomiting, or claustrophobia, he needs to inform us earlier. If yes, we have to remove the cast. If no, we can wait. We can change the cast weekly or 2 weekly, depending on the condition of the wound. The wound management usually comes off with the triangle of wound, which is the wound bed, wound edge, peri-wound skin. So all these three should be kept in a clean and optimal condition in order for the wound to heal. So in case if you are treating the wound bed with a hydrogel dressing foam, your wound edges are trimmed, but your peri-wound skin is macerated, it doesn't work. So eventually the wound is going to break down further because of the poor peri-wound skin. So all these three should be kept in mind, should be treating all these three when you're seeing a patient. So the common principles we use in wound bed preparation is the time principles, where T stands for non-viable or deficient tissue. So that needs debridement to remove all your non-viable or deficient tissue. So non-viable tissue can be from slough, eschar. Infection or inflammation needs to be treated with local antibiotics or systemic antibiotics. Local antibiotics can be silver, PHMB, and your systemic antibiotics, as I said earlier, can be from your cephalosporins and other antibiotics. Your moisture imbalance. So for the wound to heal, the moisture should be balanced. If it's too dry, you'll start having necrotic tissue. You'll start having dryness of your foot tendons. And also if it's too wet, it causes maceration and increases the bacterial load. And also the edge of the wound should not be non-advancing or undermined. So T, when it comes for your dressing selection for tissue viability, so T is, as I said, is a viable tissue. And also the ways of doing debridement, one can be mechanical, where you can use a gauze, saline gauze, and you can gently rub the wound to remove all non-viable tissues. Then you can opt for autolytic debridements using hydrogels, alginates, honey, gels. So how does all this work is it keeps an optimum condition of the wound where our body itself releases enzymes to debride the wounds. So it doesn't have any outer source. So it just keeps our wound in such a condition where our body itself responds by giving out enzymes to debride the wound. The next, you can go for enzymatic debridement, where you have collagenase, pepase, where they themselves have their own enzymes, which helps in debridement. Next is wound cleansing. So wound cleansing also keeps the infection in control. So it's a process of removing inflammatory contaminants from a surface. So the commonly used cleansers are saline, water for irrigation, povidone, superoxidized solution, antiseptic solution, and hydrogen peroxide. So the method of usage and choice of cleansers is based on assessment of wound severity. So this, over the years I've realized that if you're just going to use to clean the wound, it doesn't make much of a difference. It's only when it's soaked to a certain time where you start having your effects from your wound cleansing. Example, when you have a patient with very high infection rate, usually I go for povidone iodine. So when it comes to povidone iodine, it keeps the bacteria at bay. Okay, it helps to it reduces the bacterial load, but however, it doesn't help much in the healing process. Therefore, I wouldn't personally recommend to use povidone for too long of a period, but it's an excellent product to be used during the initial stages of infection. Your water for irrigation and saline is all very good cleanser, okay? But again, it doesn't have any antibacterial or antimicrobial properties. When it comes to certain solutions like superoxidized solutions or antiseptic solutions, it's important to at least soak the wound for a period of a minimum of 4 minutes for it to have its antibacterial and antifungal properties. Usually, what I recommend the patients is to soak it at least for 10 minutes to get an optimized antimicrobial activity from the solution. If not, if you're just going to use it to just clean the wound from outside and then close it up, it's of no much of a use. Next is debridement. So what is debridement? The removal of damaged tissue or foreign objects from a wound. So since I'm still going on with your systemic control of systemic management of diabetic foot ulcers, so I'm not going to talk about your sharp debridement yet. So we're going to talk about mechanical, autolytic, enzymatic, and biological debridements. So mechanical debridement, it's a non-selective type of debridement, meaning you'll remove both devitalized tissue as well as viable tissues. It usually carries using mechanical force, wet to dry, pulsatile, and wound irrigation. So when it comes to mechanical debridement, it doesn't have any selective ability. So meaning you are carrying the risk of removing both the devitalized tissue as well as viable tissues. So this is not as recommended when there's only a thin tissue layer covering your bones or tendons, because eventually you're going to expose both of it. Next comes your autolytic debridement, where, like I said earlier, your hydrogels and your foams, which provides optimized moisture balance, where the body itself uses phagocytes and proteolytic enzymes to remove non-viable tissue. Enzymatic debridement is use of topically applied enzymatic agents like your collagenase and your pepase, where they actually help to do the work for you. That means they help to debride the wound. The last is biological debridement, the use of living organisms to remove necrotic or dead tissue. I think most of you have heard about maggot debridement. So maggots commonly used are sterilized maggots. It's quite popular in the sense that they are quite selective, meaning that maggots selectively remove only the necrotic or dead tissue, and they don't disturb your healthy tissue, and it's generally painless. Most patients usually complain that they are feeling ticklish and slight discomfort, but not pain. So this is quite a popular method used. I stands for infection or inflammation. So this is, there's a lot of topical dressings used: silver, PHMB, iodine. Honey, to a certain extent, also has antimicrobial properties. So the choice of dressing, when it comes, there's plenty of dressing containing silver, PHMB out in the market. So it depends on the type of silver used. So usually your nano silver, comes in smaller particles and is more effective compared to your colloidal silver. And also different dressings have different concentration of silver, which is usually within the allowed amount. So it really depends on the doctor himself to assess how bad of the infection and how he wants to choose which silver he wants to use. Like I said, there's so many out there. So it depends on the doctor himself if the type of silver he wants to use. He wants to use colloidal for a lower grade infection, or he wants to go for nano silver for a higher a wound with a bigger infection. M is for moisture imbalance. So the common ones we've been using is usually the one which is found everywhere is usually gauze. Okay. The other forms of moisture management can be used as alginates, foams, hydrofibers, negative pressure wound therapy, and they have different types. So when it comes to choosing dressing for moisture management, it depends on the wound itself. So if you have a low exudative wound, you can go for gauze, or you can even go for mild to moderate grade foams. And for higher level moisture wounds with higher level of moisture, you can go for alginate, or you can go for negative pressure wound therapy. So all this depends on how exudative the wound is. And there's also dressing for odor control, which is honey, charcoal, and antimicrobial dressing. Coming to your peri-wound management. So the peri-wound is subject to damage caused by adhesive dressing removal, excess wound exudate, pressure-induced callus, and also allergic reactions to adhesives and dressings. So I've personally seen a lot of my patients having, not a lot, more to a small amount of patients where they have allergic reactions to certain adhesives or dressing. That's why I always have about 2-3 types of adhesives. If it doesn't work with the first one, I'll try to go for the second or the third one, depending on the patient. So when they have these allergic reactions, patients, usually they're not tolerant to the dressings because it causes them redness, itchiness. So all this is things that you have to ask the patients and see by yourself in the patients when you're giving them a certain type of dressing. Impaired peri-wound can exhibit pain and cause slow healing. Macerated peri-wound increases the risk of infections as well. So, like I said earlier, if your wound bed and your wound edges is clean, but your peri-wound is not healthy, it's going to increase the risk of infection, and we'll be back to the basics back. So the peri-wound management, you can use barrier cream, barrier film, non-adhesive dressings, use of super absorbent dressing, or treating with topical corticosteroids for the allergy. So all this usually keeps the wound dry, at the same time keeps it moist so that it doesn't, your maceration doesn't occur. Another popular ones that we see in wound care nowadays is negative pressure wound therapy, NPWT. So it's defined as the use of subatmospheric pressure to promote or assist wound healing or to remove excess fluids from a site. It has been used almost for the last 50 years in acute and chronic wounds. The mechanism action is via the negative pressure gradient, where the pressure in the machine is higher than your wound, and therefore it flows back into the machine. So how does it help? It removes wound fluid, desiccated tissue, removal of bacteria, improvement in blood flow, promotion of granulation tissue, and physical stimulation of cells. The best pressure, the usual standard pressure we use is 125 millimeters mercury. However, it differs given patient's age. We don't use such a strong pressure on newborn neonates. And also when it's exposed vessels or exposed organs, we do use low pressure starting from even 50 to 20 millimeters of mercury. And the latest innovation which has come up in your negative pressure wound therapy is your installation negative pressure wound therapy. I'm not sure if a lot of people have heard about the installation negative pressure wound therapy. So how it works is the negative pressure wound therapy is attached to an installation device. So the installation device contains fluid. So the fluid you use can be normal saline. It can be also antimicrobial fluids that you can use, anything from your PHMB to your hydroxyndamycin, anything can be used. So what the machine does is it instills the fluid that you're using into the wound at a given time for a given time, meaning that you can set the machine up where the fluid is instilled into the wound for maybe 10 minutes, 5 minutes. So usually, from what I've seen from using on my patient, the best time for what we call as soaking is about 10 minutes, meaning the fluid goes into the wound and stays there for about 10 minutes. And after 10 minutes, the fluid gets sucked back into the negative pressure wound therapy machine. So you can choose to soak the wound every 1 hour, every 2 hours, every 3 hours. It all depends on the doctor who is treating the patient. So it has an upper hand compared to the usual traditional negative pressure wound therapy, as it helps to wash the wound washout. It helps to keep the bacteria at bay, and also studies have shown to have for installation negative pressure wound therapy has about 40% higher granulation rate compared to your traditional negative pressure wound therapy. So the indications are usually acute chronic wounds, surgical wounds, partial full thickness burns, peptic ulcers, venous arterial ulcers, traumatic wounds, post-flap skin graft, and stage 3 and 4 ulcers. It's quite well to be used in venous and arterial ulcers because the pressure actually has a pulling effect where it increases the perfusion around the wound from the collateral vessels. Therefore, it increases the blood flow through the wound at the particular time of usage. The contraindications is infected wounds, necrotic tissues, untreated osteomyelitis, fistula of unknown source, direct application of exposed bone vessels, blood vessels and organs, malignant diseases, patient with bleeding tendencies. So usually your negative pressure wound therapy can be kept up to 7 days, but the usual practice is they keep it for about 3 days. So due to that, you can't use it on infected wounds, necrotic wounds, and your untreated osteomyelitis, because we can't actually see what's happening in the wound for the 3 days of application. Therefore, it's always you have to be very careful to use negative pressure wound therapy, as it's one of the best therapies I've seen around. But if used wrongly, over the 3 days, it can deteriorate the wound quite badly. So the complications can be bleeding, worsening infection, overgrowth of variation tissue, retained foreign body, pain. Pain is usually temporary. Almost all my patients, I'll always tell them that they would have about pain for about 30 minutes, and then usually the body gets used to it and they don't feel anything much after 30 minutes. And also enteric fistula. So all these complications have to be bad in our mind before we start using your negative pressure wound therapy. One of the particular cases which I remember was a patient with bleeding tendency. So he already had an underlying bleeding tendency. So when we started using the negative pressure wound therapy, it started getting soaked with a lot of blood. So we had to stop the negative pressure wound therapy. So all this have to be taken into account before we start using the negative pressure wound therapy. So we have to always, what I usually say is, at least watch the patient for about an hour or two after application to see how the patient is coping up with the therapy. So before I end the part of dressing usage for wound, so it doesn't mean that you have to use it individually. So meaning you can use hydrogels with your foam, you can use your silver based with also your foam or your gel. Most dressings complement each other. They do not actually cause a reduction in any of the activities. But again, a lot of research is needed further on that. So you can choose to actually use 2-3 modalities together. Okay. So next comes to your surgical management of diabetic foot ulcer. So my favorite debridement is always surgical debridement because it's the gold standard for removing damage or foreign objects from surgery. So the newer methods are laser and hydrosurgeries, but I've personally not used it because it's not available in my center. It's also recommended for removal of thick adherent eschar and also devitalized tissue in large amounts. It may require analgesia and anesthesia. So why I would say is the gold standard because you personally can remove what you see. You can open up pockets. The only thing that comes, the only side effect when it comes to sharp debridement is usually when you are trying to remove a section of slough or thick adherent devitalized tissue. You can't help yourself from removing even the healthy tissue, and also you would be causing some amount of bleeding. So not all patients are comfortable with surgical debridement because even how we can optimize the pain, but our post surgical debridement, some patients still they complain of about a lot of pain. But again, compared to other debridements, this is always the gold standard. Next is reconstructive surgery. So the structural foot deformity may predispose the diabetic patient to ulceration infections and subsequent amputation. Like I told earlier, when a patient has Charcot arthropathy, they have ankle deformities. So so there will be an area where there's excessive pressure, and due to the pressure, the wound would not be healing. Okay, so these are certain common procedures done to reconstruct the foot, where you can do exostectomy is done where they relieve bony pressure that cannot be accommodated with any other means. Arthrodesis of ankle, where they fuse your ankle joint together or your tibial and your other midfoot joints. Therefore, it doesn't. You can't move that particular joint. Therefore, it's quite stable. So it reduces the stability of the joint, and also it reduces the pain over the particular joint. Another op can be done is lengthening of the Achilles tendon, which reduces the forefoot pressure and improves the alignment of the ankle and parts of the amputation. However, because the patient has already high risk of developing new wounds, and also due to their peripheral vascular disease, there's high risk of wound complications like infections and amputations. Therefore, reconstructive surgery is not commonly done. This is an example of the arthrodesis of foot for your Charcot arthropathy, where they use screws to stabilize the ankle and the bones inside your foot. Next comes to plastic surgery, where there's option of skin graft and flap surgery. So skin graft takes on the function of the missing skin layer in healthy wound beds. Some are designed for temporary wound, but some are for permanent coverage. So the types of skin graft is autograft from your own body, your allografts from another person, xenografts from another source of usually animal source, and bioengineered or artificial skin. So so how the graft works is it takes over the function of the missing layer, meaning that it temporarily covers the wound till our body starts having epithelialization. So the primary outcome is incidence of complete closure of wound ulcers, lesser time to complete closure of wound ulcers, reduces total incidence of lower limb amputations, reduces of infection, recurrence of ulcer, change in ulcer area, incidence of reduces incidence of secondary infections, treatment-related adverse events, and also reduces the cost of treatment. I think almost every doctor here have had the same problem where they treat a large wound or the wound over the foot, especially over your soles, and after a certain extent, after a certain amount of time, you realize that it's going to take a very long time because the wound is quite a huge one. So that's where your plastic surgeons come into the picture, where they actually help to they help with the early closure of the wound and also to reconstruct the wound. So because as we know, as we prolong the wound, there will be always a chance of the wound turning into a non-healing ulcer, and also there's a rate of infections, and ultimately patients in themselves will be quite frustrated that they just stop coming for dressing because they feel that, we have done it for too long. Flap surgery is another option: pedicle flaps, local random flaps, muscle flaps, and also free tissue transfer. So this is usually done in a larger wound, and also when we have a wound over the base of our foot, because how humans are made is that the foot usually has a thick amount of fats, which, like I said earlier, it helps to disperse the pressure. So once when there's a diabetic foot ulcer over the foot, the base of the foot, and debridement is done to remove a whole chunk of the adipose tissue, even if the wound closes, that particular area will be having quite a thin skin layer, and the adipose tissue almost about 80 to 90% does not return. So therefore, patients always have prolonged pain and also a high risk of recurrence of wound. So in this type of patients, always recommended to refer them earlier to a plastic surgeon so that they can do a flap to retain the adipose tissues over that area. So factors for successful plastic surgery. So even though plastic surgery can be used, but however, if there's a lot of factors which contribute to its success, one of it is stabilization and viability of the recipient and donor site, vigilant clinical observation for monitoring the viability, the presence of comorbids and medical comorbidities, the elasticity, vascularity involved, limb is stable and mechanically sound position, and also proper wound dressings. Meaning, once you have done your graft, it doesn't mean that you don't have to do dressing and all anymore. It still needs a proper dressing till the wound heals. And also, if, example, you're doing it over the heel, you need to offload the heel so that the graft stays. And the common mindset of patients is that when they have done a skin graft, it should have a 100% success rate. But even if it's from our own body, it always has a 50% chance of either it's becomes non-viable or it becomes attached. So it's always important to observe the flap or the skin graft to make sure that it's viable. The next is vascular surgery. So revascularization improves the healing of ischemic diabetic ulcers. When feasible, it can be achieved by either bypass or endovascular procedures. So some surgeons prefer bypass, some doctors prefer endovascular procedures. So a systemic review done in 2017 shows that bypass surgery has higher technical rate and primary patency rate at 1 year. So post-revascularization, usually we start them off on platelet therapy. So the complications can be early thrombosis of graft or vessel nerve injury, graft infection, renal failure, cardiac complications, stroke, and bleeding. So usually, before when I was talking about assessment of your vascular insufficiency, so vascular surgery is one of the best ways to revascularize the limb. However, most of the patients are chronically ill, have multiple comorbids. So the selection criteria is actually reduces the amount of patients that actually can undergo vascular surgery. Therefore, it's not widely used because of the patient selection criteria, which makes only a handful of patients good candidates for the surgery. Okay, so the last part is always better to prevent. Prevention is always better than cure. So as a patient, what should I do at home? Okay, so this is what we should be advising all our patients about. So they should do a daily inspection of foot. So sometimes if the patient can't actually look into his sole of the foot, I always ask them to use a mirror or such, or ask a relative or someone in the house to inspect the foot. Avoid extreme or hot or cold water temperature. To wear comfortable shoes. Cut your nails regularly. Moisturize your feet regularly. As you know, in diabetes, patients usually have very dry and flaky skin. So it's important to tell them to regularly moisturize their foot. You can use from oil-based or water-based like lotion. As long as it has a moisturizing effect, it should be good enough. And also, if they have a slightest doubt or slightest feel that there's something wrong with their foot, do not be shy to always visit your doctor, because we always care for our patients. So the moment you have even the most silliest doubt, it's okay. You can always come and see your doctor. What you should not do, diabetic patients should not walk barefoot or use as adhesives on your foot. Do not treat your calluses or corns or your wounds by yourself. Do not use hot water bottles, and do not wear tight stockings. So most of the patients, when I always ask them during the initial stages, they always think that it's a small wound and I can treat it myself. So by the time they come to see the doctor, it's always too late. So always don't try to treat yourself. If you have any problem, you always should come and see your doctor. So long-term prevention is always up to actually the doctors and also the healthcare workers. So they should have annual screening programs where you screen for your triglycerides level, your glycemic level, and also your blood pressures and other screen to ensure that the patient is healthy and doesn't have any risk of diabetes, and also for early detection of these diseases. And patients with diabetes should have optimized medical care and treatment. As like I said earlier, you can use HbA1c as a control to see how good is your optimization, and also regular checkup for patients to hope that they are given the best, most optimized medications, and also educating patients on their disease, what is the side effects of the disease, what can occur, what they should be expecting if it occurs, and when to meet a healthcare worker when you have certain issues, and also proper supplements and regular exercises. All this keeps your body healthy to prevent any diseases, and also to keep yourself healthy.